practices. I've dealt with 3 from around the world, 1 from Sweden, 2 from Britain. I must say that this problem has been with us for the last 70 or 80 years. There's nothing new. We thought, I suppose originally, we seen these with injections. We had a lot of blindness and thought when we got hyaluronic acid as a filler that it'd be the end of it, but it certainly wasn't. In many ways, hyaluronic acid became so popular that it was really the beginning of it. That's sort of my biography. And if we look at how it happens, in this instance, it can happen 3 or 4 different ways. The first one, if we look at A, it can go through the cutaneous branches, as we know, and that's almost directly into the supraorbital or supratrochlear. B is from a remote site. In this case, you can see it's from facial artery down at the nasolabial level. C and D are through AV shunts or obviously through the orbit. Around the world, these are the different distributions. I'm surprised that the United States is so high. It is about 12 or 13 cases. We always thought that it probably was, well, it is Korea. They've had many, many cases, certainly over 200. These are the anatomical sites where it happens, nose being the most important, and then forehead, glabella, all the way back. So what I'm going to do in this lecture really is to look at the history of it, my role in it to an extent, because I disagreed for many, many years with how it was being treated. And I think now we're all aligning back to where I thought we should be many, many years ago. The first attempts to correct it were done by retrobulbar, which was like this. And at the time, I disagreed with the retrobulbar. It didn't make any sense. They're in 2 different anatomical positions. There's no direct connection between the retrovascular bundle behind the eye and the space. There's 3 layers of dura mater between it, and not only that, but it could cause damage to the eyeball, and you needed a special training to do it. And my first hesitation was an article I wrote here, and I said I have extreme reservations about this. My main reason is that the risks are high, vision rescue is unlikely, and we could use a much simpler method, the supraorbital method, that anybody could do in the office. Anybody can feel the supraorbital foramen and put amount of hyaluronidase into it. Believe it or not, from China, we had a lot of different doctors saying we should stop doing the retrobulbar. There's no evidence that it's of any benefit. Now, the way I looked at it also was, if you had a heart attack in your office, you wouldn't send the patient to a cardiologist. You'd try and deal with it yourself, particularly maybe CPR, or if you use adrenaline or verapamil, you've got the ECG. Why would you waste time sending a patient to the hospital? And I said, it's even more important with your eye, because you should be able to deal with it yourself. I'm not saying don't send it to an ophthalmologist, but for God's sake, you probably have 30 minutes. You're the one with the hyaluronidase, and instead of trying to stick it into an area that's quite complicated, it's quite simple to palpate the supraorbital foramen and use it there. We had many cases. Greg Gugman, 2016, Mike Klug in Australia, reversed one of the first ones. At St. Petersburg, just after that, we had 1 or 2, and then we started getting 5 or 6 in. And I had one myself that I reversed, but I didn't want to claim it because the patient was regaining their sight anyway, and I thought that maybe it might be inappropriate to be seen to be injecting hyaluronidase into a patient who probably was... They took a half an hour to reach me, but by the time they were in my waiting room, they could at least partially see. This is an interesting case here by a colleague of ours in Argentina, Patricia Barrera, who reversed this one with the help of Ferdinand Silkovic. So immediately the patient had lost their sight. They used the supraorbital method here. They had evidence embolically of the ophthalmic artery, and believe it or not, they had used my book on complications. If you haven't got it yet, I'd advise you to get it. It's a bit of a Bible of aesthetic complications at the moment, and it's now translated into Chinese as well. Before IMCAS this year, we had a situation where Jean Carruthers and Kate Balancy reviewed the original paper and said that we should use the supraorbital or supratrochlear method and not to use the retrobulbar. So that was nice. Jean came to us in IMCAS and updated that. Obviously, it doesn't work all the time, and it works. And we have a colleague who also came to IMCAS. Hugh invited him some years ago, Ha Hong Nguyen, and he presented his method of going in through the femoral artery with a thrombolytic agent and hyaluronidase, making its way all up to the ophthalmic artery. And as a consequence, it will not go into the central retinal artery because it's too small to use hyaluronidase there. So this is a paper that he presented originally about 3 or 4 years ago, where they took 10 cases, reversed, and got 6 back. Ha Hong works in this hospital in Ho Chi Minh City. They deal with a lot of other complex cases in the surgery unit. And what we think now, and we have a world group dealing with vascular blindness, that maybe we shouldn't even send them to ophthalmic surgeons. What we should do is send them to stroke centres, because in stroke centres you already have the radiologists, you already have the thrombolytic agents, and the ophthalmologists will work in integration with those. Because if you're sending, and I know because I chatted to the ophthalmic surgeons in Moorfields in London, if you want them to set up a unit, they may never see a case in 10 years, or they may see 1 in 5 years, whereas the stroke unit is already in position. So if we could change our mentality to send patients to stroke units, and don't forget also, when you get an embolism or blindness, 34% also involve the brain. It's not just the eye on its own. This was the situation in Vietnam before 2019. All the patients obviously went blind. They ended up in ENT and all the rest. And since this unit has come on board, they have had success of almost 78%. They've had 36 cases now, I think, of blindness recovered. And one of the problems is that when you get your eyesight back, unfortunately, the eyeball has shrunk a little bit. So some of these patients have reduced visual acuity. As a consequence, they may need lenses. Speaking in IMCAS, we were with him in Georgia last week, and he has a new paper, which is even more interesting. So I'll spin through that. I know we're running a bit late, and it's my fault, so as a consequence, I'll try and spit. So these were Dr. Nguyen's first cases, which he got back. This was us in IMCAS some years ago. This year, ophthalmic surgeons have come together and came up with a new method called vitrectomy. Now, whether it works or not, we don't know, but I'll spin, this is it here, and this involves a retinal surgeon performing a vitrectomy, so they're reaching the central retinal artery by a different method. Rather than trailing a catheter all the way up from the femoral artery, they're actually going in around the side of the eye to reach the central retinal artery that way. It's probably a good theory, but at the end of the day, we have to get hyaluronidase within the central retinal artery itself for it to work. So we're getting closer to a solution.